If you've ever dealt with hemorrhoids, you know it is literally a pain in the butt. And most people don't realize it's a vascular issue. And there is something you can do about it. Hi, I'm Kym McNicholas, and welcome to the Heart of Innovation. Dr. John Phillips is off today doing what he does best, saving those piggies, saving legs, saving lives. In studio, we have Dr. Misha Ginsburg, an interventional radiologist from South Bend, Indiana, and Dr. Zuhair Yaseen, a gastroenterologist, to talk about the increasing prevalence of hemorrhoids, which impact more than 50% of adults at some point in their lives, and a newer, minimally invasive solution that many people don't even know exists. So I'm really excited for this conversation today. But first, Dr. Ginsburg, I hear we have a moment of inspiration.
Dr. John Phillips, spectacular vascular moment of inspiration.
So, as you said, stigma. So, our quote for today is embarrassment keeps us silent, but courage demands that we speak. So, the topics we avoid out of shame are often the very ones that bind millions in unnecessary suffering. Breaking that silence is the first act of healing, and for ourselves as well as for others. So, here we are to start the show.
And I love that, breaking the silence in very wise words. Nice job. This is going to be a really good show. I'm hoping that having this discussion publicly across the radio, across the web, that it'll inspire people to actually speak up, break that silence, and stop the suffering. I want to get into what the suffering really looks like for people. Thank goodness I have never had hemorrhoids. I remember my mom at one point did have them, and they could bring a grown woman to tears. And so I want to talk about that. But let's welcome Dr. Zuhair Yaseen. Thank you so much for being here. The silence needs to be broken on this.
I think it is time to break the ice and talk about this subject because it is very, very common. Most of the time, people come to our office and they're so embarrassed. They want to talk about something so it is not timely. They really don't want to bring it up. I think in the context, the way we bring this up, most of the time people are worried about cancer. So there are, the first thing comes whether it is pain or it is bleeding. Most of the time, bleeding what brings people to the clinic. The thought of having blood scares everyone. So especially once you get to a certain age, people start thinking about, okay, blood means cancer. So in that context, we are the one who are kind of in the first line. You get a referral, you go to the family doctor, primary care. Oh, you need to go to the gastroenterologist because we think it is a serious issue. So we need to deal initially with the emotional aspect of how to deal, kind of calm patients. Not everybody with a rectal bleeding having cancer. And then you get to the second, once you rule that out, then you find, oh, it's only a hemorrhoid. Well, it's not only a hemorrhoid, it's a nuisance. Whether it is a pain that you're dealing with, pain is different from bleeding. Obviously, it manifests itself with different issues. So I think when we approach this from a patient point of view, A, we need to assure them. B, we need to do our own work, make sure there's nothing serious. And C, we need to direct them in the newer or most of the traditional way of dealing with hemorrhoids. Obviously, that also has different aspects. One of them is the treatment, and the other is prevention. How do I get rid of this? Now, most of the time, people don't realize, and Dr. Ginsburg can, talk about this. Hemorrhoids are just normal veins, just like we have veins in our legs.
See, I didn't know it was a vascular issue. Literally had no idea until my dad had chronic venous insufficiency that some procedures didn't seem to solve. He went to Dr. Miguel Montero Baker, a vascular surgeon in Houston, and he said, here, take some Venexa, this over the counter. We went on Amazon, looked it up, and the first one we saw was for hemorrhoids. And I called Dr. Baker and said, he doesn't have hemorrhoids. He has chronic venous insufficiency. He said, Kym, it is a vascular problem. You need to actually use this same medication, which is not only indicated for hemorrhoids, but also for chronic venous insufficiency. So, talk about what are hemorrhoids, both anatomically as well as physiologically, and why is it a vascular issue?
I think maybe I'll leave this to Dr. Ginsburg. He deals with the angiography more often than I do, so maybe I'll yield that to him if you don't mind.
Sure,
Sure.
Dr. Ginsburg.
Yeah. So basically, once you look at angiographic, which is basically taking pictures with injecting dye through the blood vessels and specifically arteries, at how hemorrhoids look, you know, it has basically a signature look that is very impressive. And what I mean by impressive, those things do not behave like regular veins. Um, Real internal hemorrhoids behave more like a vascular malformation, like a high flow type of vascular tissue that essentially at increased risk for bleeding, rupture, and so on and so forth. So, the actual anatomic kind of correlate or anatomic explanation of what it is, as Dr. Yaseen said, it's just normal tissue, right? It's just that normal tissue under increased pressure. And what it means is that, internal hemorrhoids sits at what we call anorectal junction, which is basically at the end of your rectum and the beginning of your anus, and it serves as a secondary continence mechanism uh, for us, right? Like if anal sphincter is a primary continence mechanism, that's another way to prevent incontinence, right? So people who have frequent constipation or diarrhea or both, are definitely more predisposed to developing worsening sort of internal hemorrhoids. And essentially, what happens is as that tissue gets engorged with blood, it serves us as a secondary continence mechanism. Very similar in terms of physiology and anatomically to what tumescence happens for male penis. This is not a swear word. This is just the same type of tissue. Uh, uh, it's called cavernosal spongiosum, which is basically engorgement of that tissue as when the rectal vault is filled with stool. And so that causes pressure and on the veins and causes engorgement of the tissue.
Well,
So
coming up here, right on the Heart of Innovation and KDOW. Nice little cliffhanger there, Dr. Ginsburg. More with Dr. Ginsburg and Dr. Zuhair Yaseen on hemorrhoids, your pain in the butt. Coming up next.
How many procedures are you willing to go through? Is it worth going through that many, or would you rather just?
That's funny. Was it worth it? Oh yeah, I have my leg, man.
Amputation should absolutely, positively, 100% never be a first-line treatment.
What an incredible operation! What an incredible lab you have here.
Without a doubt, we're underdiagnosing peripheral arterial disease. It has not gotten the attention that it should because it is a killing disease, it is a disabling disease, and most importantly, it's a disease that we now have great treatments for.
Okay, let's go to the next one.
They were going to amputate it, and I needed to consult with my family. Did I want it off here or here? You're just shocked. It's scary. I don't even know how to explain it. You're 42 years old.
We're waiting till people are at the end of the spectrum and almost beyond hope. There is good care available here. Closed minds are what we have to get rid of.
Welcome back to a real pain in the butt discussion. And I don't say that to make fun. What we're trying to do with this conversation is to really break the stigma, break the silence of hemorrhoids, because the earlier you get to the doctor, the better. And before the break, we had Dr. Misha Ginsburg talking about the fact that hemorrhoids are actually a vascular issue. Dr. Ginsburg, so that really probably changes people's perception on what causes hemorrhoids and possible treatment options as well, does it not?
Well, it's a vascular/GI issue. It's a vascular tissue in a GI tract that can bleed, right? And it's an area that is, for some people, and in today's days and age, and why the prevalence of internal hemorrhoids is increasing in the first place, is a lot to do with lifestyle, obesity, our
Really?
choice of diet and nutrition and low fiber diet, and some of the other sort of habits, like sitting on a toilet, looking at your phone for and browsing your phone, that increases the risk
Everyone's a
of
violator. Yep.
right, of
Hmm.
developing more so internal hemorrhoids. And so for people with increased pressure in the abdomen and a lot of straining, which may be related also constipation or diarrhea or both, ultimately that tissue that has a normal sort of function in our body enlarges, it hypertrophies it and swells up. It swells up with blood, and ultimately, under enough pressure, that tissue that's not designed to have so much pressure can have small little nicks and fissures that lead to bothersome sort of bleeding that can be just on a toilet paper or in a toilet bowl, or can lead to much more significant bleeding. Most patients have the bleeding as a nuisance, but there's certainly a spectrum of presentation in internal hemorrhoids. And for some people, it can be quite severe. For some people, it can be mild. And there's ways we sort of stratify them by something called hemorrhoid bleeding score in terms of how severe are their symptoms and how impactful they are on their quality of life. The
Okay, so there's
main treatment,
internal and external hemorrhoids.
yeah, I'll let Dr. Yaseen address that. But yeah, for sure, we are talking about
Okay.
internal hemorrhoids today. I think he'll do a better job sort of explaining that.
Yeah, Dr. Yaseen, can you go into that? And then I have literally built up so many more questions in my head about the prevalence and diet and all that stuff, but I didn't realize. So you have two different types. You have internal and external. What's the difference between the two, and which is more common?
They're really continuum. It
Okay.
is, if you think about it, I always tell patients, like we go back, it is normal vessels, just like we all have jugular veins. We all have veins in our legs. You can see some people more prominent in their arms or their jugular vein or their legs. Same thing for hemorrhoids. And these vascular system, serves obviously our need. So for the external hemorrhoid and the internal hemorrhoid, just an anatomy where the blood is coming from the bottom and blood coming from the top, and they kind of meet, the source of the or the origin of the blood. So it is, for all intended purposes. I mean, the most of the time people are feeling the external. That's when they feel it. The bleeding is, we call it painless bleeding. It is the internal hemorrhoids. The feeling most people need to know, we don't have any feeling inside the rectum. So once you go above certain level in the rectum, even if put with a biopsy or needle, patients don't feel it. More like the umbilical cord. Once you start having pain, it is usually outside the rectum into the anal area, and that's where people start having more pain. Now we can go. I mean, you can tell me wherever we want
Yeah, no,
to.
I'm curious. So people, this is one of those things that it's almost something that silently creeps up on you and until the point of no return. So by the time they start feeling the pain, it's already wreaking havoc inside of you. And the moment you start to feel anything like that, you really should go to the primary care doctor, or if you have a PPO, get to the gastroenterologist sooner rather than later.
Absolutely. And it is when we talk about pain, again, it's a continuum. For us, I'm more concerned about the bleeding, where the patients are more concerned about the pain. Obviously, the pain happens from multiple things. One of them could be the hemorrhoids get thrombosed, get a blood clot. Again, there's no different than a blood clot anywhere else. It hurts. And that is where sometimes you need a surgeon to try to cut it and remove it. Those are rare, but those are acute. They're very, very painful. Most of the time, I don't see them. They go to the emergency room. That is, very painful. The other painful condition is, which could be also associated with hemorrhoids, we call it anal fissure. Basically, anal fissure is like a paper cut in the skin. So people are constipated, they have hemorrhoids. We call it anorectal disease, or we call it rectal outlet. That's kind of the way it is a disease. So it just kind of opens up and it is very painful. So it's not necessarily the hemorrhoid themselves that are painful. It is the process of going where people also could have incomplete evacuation with large amount of stool sitting in the rectum, cannot be expelled. There is something we call pelvic floor dysfunction. Pelvic floor dysfunction, I always tell people the way we have to understand, and maybe this is what patients need to understand, the way the rectum works is think of it when you go to Walgreens or any of those stores, you come closer to the door, the sensor sense that you are there and it opens, and then you just go in and it closes. Now we have the same system built in the rectum. Stool comes down, get to the end where it's supposed to activate those sensors, and it's supposed to open up, and then we have a bowel movement and it closes off. Now this seems kind of more easy to do indoors, but it is difficult to do in real time for patients. And this is where that's kind of the essence of where you talk about the cause of anorectal dysfunction, where things don't work very well, and that leads to a cascade of events, eventually can lead to hemorrhoids. So unless you're able to to kind of break that cycle, break it somehow, then it is going to be a physical pressure sitting on a very vascular area, and it will impede the normal flow of blood and would just push it out. Now, early on, it would be maybe just, in and out, will people have a little bit of engorgement and it will come out. But later in life, or later, with repeated damage, it will actually become scar and it cannot come out anymore.
Wow. Well, coming up right here on the Heart of Innovation, I mean, this is really an eye-opening conversation. I think we already got Dr. Ginsburg's perspective on what's leading to this. I want to hear from Dr. Yaseen as well. I'm sure he's going to affirm what Dr. Ginsburg said, but we definitely want to reaffirm what you should not be doing that may be leaning to your pain in the butt. So stay with us right here on KDOW.
Your type of condition is called critical limb ischemia. It's the most advanced form of P.A.D. or peripheral arterial disease.
Every 4 minutes, there is an amputation in this country due to P.A.D. and diabetes. We also know that 85% of these amputations are preventable with early intervention.
It's a flip of the coin. Patient prognosis is tied to whether or not they are referred to a true expert in the management of peripheral arterial disease.
Do you know if your physician is an experienced CLI operator?
When you're in the hospital dealing with doctors and stuff, you figure they know what they're talking about.
The skill level varies doctor from doctor and hospital to hospital.
Patients with limb threat are in constant fear. The depression that someone experiences after they lose a limb is equivalent to those of losing their spouse of 40 years.
I was stuck in a wheelchair close to 2 years, and my husband had to quit work.
I didn't know what to do at this point because we had nothing but infections and hospital stays and infections and hospital stays.
And they took one toe, another toe, and then it was another toe, and then half his foot before he was even diagnosed with P.A.D.
And all I heard was, "What are we doing here? Just cut it off." And I pulled the curtain back like, "Are you kidding me?"
Do you really want to go through all that?
That's crazy. That's insane.
The protocol is to send them to amputation. Always, always, always get multiple opinions.
We do have options.
We need to listen more to our patients.
If you're going to chop off their leg anyway, why not just let someone else try?
This is the progression. First comes the wounds, and then comes an amputation. And I wasn't going to accept that.
So that's what it's like to try to save a leg.
Hey everyone, welcome back. Before the break, we had a very descriptive conversation about how our system works to excrete all what I call the trash in our bodies. And I was really curious during the break. I mentioned to Dr. Yaseen that I'm curious, when you're sitting on the toilet for a very long period of time, and in the way that the toilet is designed, you mentioned that our body is like an automatic door system at the supermarket, Walgreens, wherever it might be. And your system kind of goes, okay, waiting for the door to open. Okay, door's open, let's go. But if you're sitting there on your phone, or you have some other reasons why you might be sitting longer, you might feel constipated, you might have excreted some, but you still might feel like you have more left. It's almost like the elevator, door, that if you stand in the middle of the elevator door and it's going, we gotta close, we gotta close, we gotta close, and it just builds up this pressure and then the alarm goes off. Is that kind of what's happening where these hemorrhoids are forming?
Absolutely. I think you nailed it. And I think unless we understand why it happens, we won't be able to prevent it, because you want to talk about prevention. Now, treatment is, we always have the Ginsburgs of the world. They can try to help us when all fails. We're talking about if we understand the anatomy, and I will go a little bit more, again, descriptive. The rectum has an angle like this. So it's
Okay.
more like 70, 90 degrees. And that is more of like if you have a tube and there is a muscle kind of strangulated in the middle, so we don't leak when we're walking. So that's kind of the analogy. And that kind of angle, when we have a bowel movement, is supposed to go straight. So from kind of twisted to kind of go straight, so we can have our own normal bowel movement with a little bit of straining or pressure. Now, what prevents that is obviously, this is maybe can go too far. Pregnancies can alter, weaken the muscles, can, women who ended up having episiotomy, they can cut the nerves, can affect also the feelings. But the muscle that is actually supposed to relax to make it kind of straight may not be working properly. And this is where you talk about people sitting on the toilet. You can be pushing against a closed door. Like you said, you're pushing against a closed door. And basically, the stool is not going anywhere, but because of the pushing, you're pushing those blood vessels out. And that is counterintuitive. There was a recent study, I think you were talking about earlier, recently, with people just kind of looking social media and on the toilet. Absolutely not. And I always tell patients, so this is also common, if you're sitting on the toilet more than 2 to 5 minutes, you shouldn't, because there's something definitely wrong, because you're pushing the hemorrhoids, you're not pushing the stool anymore. So that is kind of where that is kind of one preventive. Again, if the sensors are not working, that's a different issue. But we're talking, you're making things worse. You're pushing against a closed, that is not what you're supposed to do.
And so at what point should they be going to the doctor? It sounds as though, because there is a stigma to it, that they're going to the doctor too late. Walk us through the process of the first indications of this nuisance. I don't know if you would consider it a disease or simply a nuisance, but I guess it can progress into a grand or chronic disease if it's not treated properly sooner rather than later. So from the beginning, I would imagine you start to feel something. Tell us what you feel. And I would imagine going to the store and picking up the preparation H.
Yeah. Most of the time, people are going to pain or bleeding. That's going to be what brings patients to treatment. Most of the time, people, when they're wiping, they will feel, we call prolapse of the hemorrhoids. Most of the time, that doesn't bother them too much. The pain, when they become more painful, because that's physical pressure. Blood vessels are dilated. That's when you go to the store and use preparation H. There's Recticare, which has a numbing medicine. literally the same numbing medicine that the dentist used. They put it, so it numbed that area. It's just a physical friction, any type of physical tension, just like you twist your ankle or your knee. That is kind of what the medicine does. In addition to some of the medicine will shrink the blood vessels a little bit.
But it sounds like they should go when they start to feel it. If the first sign is not necessarily pain, but they feel something that is not anatomically correct there that they would normally feel, that would be the time to go to the store, get the preparation H, right? You don't need to call the doctor at that point. See if that works.
Absolutely. Most people are not going to the doctor. I mean, we don't necessarily tell patients, but I know from ourselves as being human being, most people are not going to the doctor early in the stage. So what brings them, either it's persistent swelling, bleeding, or pain. This is where people actually seek help. So I don't know how many patients are treating themselves, but I can just go into the aisle where the preparation H and the Recticare, I mean, people are buying those on a regular basis. So should they be going to the physician?
Right.
I would just say anything that's persistent. I mean, for us in medicine, we have a rule of 3 weeks. Anything that persists more than 3 weeks, anything that is associated with alarm symptoms. Alarm symptoms means pain that is getting worse, or if you have bleeding, those are alarm symptoms. Or if you're having, like persistent constipation, I think this is where the chicken or the egg, people also become constipated because of pain. They're just afraid of going to have a bath, going to the bathroom.
So when you have a repeat visit to the pharmacy to pick up the preparation H or whatever it might be, that's a signal, get to the doctor sooner rather than later.
Absolutely.
And then what happens? Walk us through your process, your thinking process for treatment. What are the options once they come to you, depending on their presentation of disease or nuisance?
Sure. I mean, in our experience, we are selected, group here. So most of the time, I don't see the patient in the first time. Most of the time, they're going to their primary care provider, nurse practitioners, family physicians, and they will do in-office rectal exam, and they will find out, if there's anything serious, anything unusual. And that goes on depending on the age. I mean, most of the time, people are less than, 30, 35. Common things are common. They'll just leave it a little bit more time. If you're over age 35, 40, most of the time, that's when they refer to us. And when they're referred to us, at that time is not so much for treatment. It is to make sure there's nothing serious going on. That is when we recommend doing a colonoscopy, and that's why we do it ourselves. And then after that, if we find something unusual, most of the time we don't, then we'll just say, okay, is this something doable, just over the counter? We can maximize this or or prevent the instigators. Or at that time, if nothing works, and we can go about this for a while. Some patients who are taking blood thinners, some patients who are a little bit older, it becomes, okay, well, they don't know, they bleed every week. Then that's when Dr. Ginsburg will just say, look, we've tried this, we've tried the other, there's nothing wrong. Can you help us here? Because we cannot let this person bleed all the time.
And coming up next, right here on the Heart of Innovation on KDOW, we're going to get to Dr. Ginsburg and hear about this new minimally invasive technique. I guess it's not new, but it is newer. Many people don't know that it even exists, or it's an option to get rid of their pain in the butt. So stay with us right here on KDOW. Don't go away.
When your sugar runs high, it's more than a sign. Diabetes creeping in, it's a dangerous line. Pre-diabetes too, don't think it's too light. It can lead to PAD, so start the fight. Sugar's sweet, but the cost is real. High blood sugar makes your arteries feel clogged. Slow flow, it's a ticking time bomb. Catch it early, stay strong, and keep your legs on. Sugar's not so sweet when your leg is in pain. Not controlling sugar is where peripheral artery disease sets in. Got sugar? Get checked. Don't wait too late. Save your legs, save your life. Take control of your fate. Leg pain, cold feet, neuropathy too. These are signs diabetes caught you. High sugar's the link, poor circulation and pain. Left untreated, your leg might end in flame.
Hey everyone, welcome back. We're going to get into this new minimally invasive procedure in just a moment, but standing right next to me in studio is my dad, and he does have a question for Dr. Yaseen before we talk to Dr. Ginsburg. So, benefits of being right here in studio, right, Dad? Okay, ask your question.
Doctor, I have a question for you. Since you talked about hemorrhoids and their treatment and that, what has changed in the past 75 years? I remember my dad having hemorrhoids removed in the late 50s, and they had what they called the Cottontail Club, a wing of the hospital, which had all hemorrhoid patients that surgically had their hemorrhoids removed.
That's a really good question, actually.
Yeah.
We don't do that anymore. We do not recommend it. Don't. There are better things to do now than that. I mean, people who have had hemorrhoid surgery, I can tell you, they come back with other problems. One of them is, pain and constipation, and also scar tissue. So surgery in the old fashioned, there is very little to kind of recommend it at this time. We have better things.
That's good. And better things include this new minimally invasive approach to taking care of these hemorrhoids. Dr. Ginsburg, walk us through what is this new option that gets you as an interventional radiologist involved with this particular vascular problem?
Sure. So I think, I'm going to go a couple steps back. I think Dr. Yaseen started talking about it, but, once he sees those patients that are bleeding and have symptoms that are significant enough that they're looking for something that is more than just preparation H, and a little bit more than just changing of their lifestyle, because it's already bothersome enough for them. And even with all the changes in their lifestyle, they're not able to address those bothersome symptoms. The options are kind of a spectrum. There's a grading to internal hemorrhoids from grade 1 to grade 4 in terms of both their location and their sort of protrusion, or we call it sort of herniation, right? So you can have localized internal hemorrhoid tissue that's bleeding or symptomatic, and then all the way to the fact that they're out and are not reducible hemorrhoids out from the rectum or are out of the anus. So for that, based on the grading of the internal hemorrhoids, there's different type of tailored approach from treatment and treatment escalation. So for grade 2 internal hemorrhoids, usually within the GI guidelines and recommendations, the more common one is rubber banding, okay, which is basically placing a little band around the internal hemorrhoids, or several of them, because they usually come not just as one but several, and over a couple of days they will fall off, right? That procedure is well tolerated, and sometimes requires repeating, but it doesn't have a very good sort of long-term efficacy. So we'd say anywhere between 35 to 50% of recurrence at 1 year. So it has to be repeated frequently. And Dr. Yaseen, feel free to jump in and correct me if I'm if I'm saying something wrong. And then ultimately, because of the high recurrence rate with the rubber banding, and obviously we're talking, your father asked a very good question, that 70 years ago you had a whole hospital wing dedicated to hemorrhoids. People tried to come up with some other solutions. So in the GI world, realizing, like you said, Kym, and you've been surprised that it's a vascular tissue, and it's not just a vein, it's really more than that. So there's definitely an arterial component, which is a high pressure artery, high pressure blood vessel that contributes to it. They come up with something called Doppler guided hemorrhoid artery ligation, which is essentially taking a Doppler, like about where Doppler has a sound, right?
Yeah, the ultrasound.
And it's a sound of a pulsation, right? Sound of our pulse. So that sound there is a sound of that, in the rectum. So if you put a ultrasound transducers through the rectum and you start listening to that sound, you can find the blood vessels that are supplying the internal hemorrhoids. It has a whooshing sound, right? And so if you can find it and locate that sound, you can put a suture around that artery, and that's called Doppler guided, meaning guiding through the ultrasound a suture to suture tightly that artery. And you can do 3 or 4 of them in one procedure. And that actually is a more effective way of addressing bleeding internal hemorrhoids. And people start doing them, and they saw that actually at some point in time they actually randomized and controlled in a randomized controlled study, which is kind of a gold standard for evidence in medicine. And they saw, oh yeah, like there's only 30% recurrence rate at 1 year for people who get Doppler guided hemorrhoidal artery ligation compared to rubber banding. So that was a positive signal. And then people started understanding, well, that still can be quite uncomfortable. As you can understand, ultrasound probe through the rectum, sutures through the anorectal junction there to try to tie off those arteries. Is there a different way? And that was like kind of the light bulb moment, right? Like, okay, if those are arteries, we're going for the whoosh sound. Is there a better way to get to the arteries that are essentially supplying those internal hemorrhoids than through the rectum, not requiring that type of instrumentation? And yes, that's our field, right? That's a field of vascular interventional radiology. And essentially, historically for decades, we've been stopping bleeding all over the GI tract, and not just, but GI tract specifically. And someone actually in France, Dr. Vidal, and he needs the full credit here, in about 2010, started that treatment of what we call hemorrhoidal arterial embolization, and developed a technique called Ambroid technique. But essentially, it's the same technique we use for embolization of any bleeding in the GI tract, with some modifications to tailor for internal hemorrhoids. And over time, we built enough evidence to show that this procedure is actually much better tolerated by patients, right? Because it doesn't involve instrumentation. It's certainly much more better tolerated than something called hemorrhoidectomy, like your dad said, which is kind of the end spectrum. And some people do need that, especially for grade 4 hemorrhoids, but it is a highly morbid surgery that many of the patients I see describe as a worst experience of their life because of how painful it is, right? And some of the other potential complications, like Dr. Yaseen mentioned, which is incontinence and issues that come with the hemorrhoidectomy. So this is kind of a procedure that fills a nice void for patients who are definitely afraid of the surgery and want to avoid surgery at all costs. And I've seen patients who've been suffering for years or decades with this just to avoid. Yeah, definitely. A lot of people suffer in silence, and you're just amazed every time. I see a lot of these people, and I see a lot of those patients, and I know a lot of people change their lifestyle drastically just so that they don't end up bleeding out, so that they require the hemorrhoidectomy. So this procedure through the blood vessels, like any angiogram that would be performed, and it's from a standpoint of view of an interventional radiologist, it's one of those more relatively straightforward procedures to perform. Doesn't require some tremendous fancy sort of high technical sort of skills. I would say it's a procedure that average interventional radiologist can perform. It just needs to recognize when to come into the clinical spectrum, when you can actually help the patients, recognize that the disease process is not just a nail and you're a hammer. There's a whole spectrum, right? Like you want to talk about the fact that, yeah, we can treat those internal hemorrhoids and shrink them and shrink the tissue and stop it from bleeding. But if you don't do anything from lifestyle standpoint of view, they will recur, right? This is a tissue that we're not taking away. So we need to emphasize to our patients the fact that we want them continue and emphasize changing their lifestyle, preventing constipation, trying to lose weight, and doing all the right things from lifestyle choices, because those things will come back. Now, the recurrence rate for this procedure is definitely better than the Doppler guided ligation or rubber bending. And we say it's about anywhere between 85 to 90% recurrence free at 1 year, although, evidence and and some of the studies show maybe 80 to 90, but definitely better from a standpoint of view of the other less invasive gastroenterological options. All
And
those
coming up
things
next,
are
right here on the Heart of Innovation, another cliffhanger here, Dr. Ginsburg. Stay with us right here on the Heart of Innovation on KDOW. Don't go away.
Do your legs hurt when you walk? Do you feel cramping or numbness that makes you stop and rest? This could be more than just getting older. It could be peripheral artery disease, also called P.A.D. P.A.D. happens when arteries in your legs become clogged, limiting blood flow. And when blood can't flow, your health is at risk. P.A.D. affects millions worldwide. If you have diabetes, high blood pressure, high cholesterol, or if you smoke, you're at higher risk. Symptoms may include leg pain when walking, slow healing wounds, or numbness in your feet. Some people don't notice symptoms at all until it's too late. P.A.D. is serious. It can lead to amputations, heart attacks, and strokes. But the good news? P.A.D. can be treated if caught early. Talk to your doctor. Ask about a simple P.A.D. screening test. Protect your legs. Protect your life. Every step matters. For more information, visit padtest.org or call our LegSaver hotline, 1-833-PAD-LEGS.
Hey everyone, welcome back to this show. Before the break, Dr. Misha Ginsburg from South Bend, Indiana was talking about a newer, more minimally invasive approach to treating hemorrhoids. It has an 80 to 90% efficacy rate at 1 year. No reoccurrence at that point for most patients, which is huge, but a lot of it is dependent on you, the patient, and getting those lifestyle issues under control, losing weight, eating better, lots more fiber in your diet. I know for women, 1 to 2 bowel movements a day is usually healthy. Men, 2 to 3. We'll get more into that in just a moment. But Dr. Ginsburg, lots of questions coming in. The length of the procedure, what's the access point for it to access the arteries? Is it through the groin? Is it through the wrist? Just walk us through some of the basics if you can.
Sure. I mean, we access the blood vessels through the groin, like for many other procedures as well. And that's kind of probably the easiest way to access those blood vessels we're talking about. And the blood vessels we're trying to get to are called superior rectal arteries. There's some variations in the blood supply to the internal hemorrhoids, but those are the most common ones in about 80% of the time. And sometimes we need to modify certain things in access. But ultimately, groin access is the most efficient way to get there. And we use spaghetti-sized catheters, like angel hair spaghetti-sized catheters, ultimately to get to the blood vessels supplying the internal hemorrhoids. And then we embolize them with combination of usually of microscopic particles, like sand-like particles, and some coils, which are kind of internal clips. All of that delivered through the angel hair spaghetti-sized microcatheter, which is a hollow tube that gets guided there under guidance of low radiation x-rays like fluoroscopy and angiogram, which is injection of dye through the blood vessels. So the procedure takes about 60 minutes, not more.
Okay.
And usually the patients is a purely outpatient procedure where they'll recover for about a couple of hours, 1 to 2 hours, and then get to go home. They may have mild discomfort from the procedure, but should not have any significant pain. They usually go back to work within 2 to 3 days.
And Dr. Yaseen, I mean, what do the results look like when the patient comes in to you for follow-up after this procedure?
We really look for bleeding. And I have several, early on, I wasn't really on board with this till Dr. Ginsburg came, and actually it was proved patients are less transfusion. And I'm talking the results for the bleeding. People are not going to the hospital back for transfusion because every time they go, they get a colonoscopy. Who wants to get a colonoscopy? Because we don't want to. So I think to me, that is what we look for. How many times they show up to the hospital for bleeding and getting a colonoscopy. And I'm buying into this. I think we had only one patient had the procedure twice. For the most part, they all did fine.
Thank you so much, Dr. Zuhair Yaseen and Dr. Misha Ginsburg. We really appreciate you sharing some really important information to get rid of our pain in the butt. Thanks, everyone, for joining us. I hope you have a wonderful weekend. Make sure you go to our YouTube channel, youtube.com/the @ The Way to My Heart for more great information and shows like this.